So it goes, Grand Marshal, any attending astronauts.
Jake, you were with the town of Dane, replied to Andrew's reminder email for tomorrow. He said, "Well, get there as soon as I can," but he's one of the radio interviews as the candidates. They're doing all the candidates for
What?
like all the people that are running for commissioners or governors. They're doing live interviews with them online.
I don't know if I would share.
The radio.
Primary.
And then I text you, right? There's Trevor. Hey, you want to listen to this guy that's going for governor? Talk about EMS. He just mentioned how the volunteers. We all know that.
Oh, we
Yeah.
support those. Need to help.
Yeah. He smirks. Hi, baby. Yeah, hi. You're a smirker.
By receiving this award, does Dakota automatically qualify for any foundation awards to secure, or does he have to apply separately?
You guys have
Oh.
I was like, what's red listed?
You can only go to Everest once.
That's good.
What's up, Ronan? Which one?
Each one, 247, been 247.
Because I just want to know if so.
I just wait.
How are you? How's your daughter doing? Is she still here?
Yeah, she's still here. Yeah, she leaves next month. Yeah. She keeps sending me Venmo requests.
Okay, we'll bring the to order the 29th of July, North Lincoln County Hospital District Board meeting. Public visitors, welcome all of you here. It looks like we have a few, mostly staff, I think, so we welcome you also. Looking for a motion on the meeting minutes for June the 24th.
Move to approve the minutes from meeting on June 4th.
I second.
Moved approved by Mindy, seconded by Clint. Any discussion, changes, amendments? I think I had it. I didn't have anything else. Okay. It's been moved and seconded that we approve the minutes from the board meeting of June 24th. All those in favor?
Aye.
Any opposed? We have any changes to our agenda today? Seeing none, look for a motion to approve the agenda as
So moved.
moved by Addie, seconded by Mindy. We approve the agenda as written. Any discussion? All those in favor?
Aye.
Any opposed? We'd like to now do our star performer recognition. Who's in charge of that? I don't see Sadie here. See her?
I'm remotely, unless you are.
You're doing great. Oh, sure.
I'll be Sadie today.
Great.
Thank you,
Okay.
Tori.
So today we are going to recognize Dakota Woolworth. He is with EMS and he is being honored with a star award for the exceptional care. Why don't you come up here? I know. So Dakota
Better hiding spot.
is being honored with a star award for the exceptional care, professionalism, and compassion he demonstrated while responding to a patient who had suffered a painful fall and a broken femur. During an incredibly frightening and difficult moment, Dakota remained calm, reassuring, and attentive, helping the patient feel safe and cared for from the moment he arrived. His genuine kindness made a lasting impression. The patient later described him as adorable because of the comfort and compassion he provided during a very stressful experience. Dakota's steady presence helped ease her anxiety, keep her calm, and ensure she received excellent care throughout the response. Dakota handled the situation with patience, teamwork, and great respect, taking every precaution while moving the patient to the gurney and doing everything possible to minimize her pain. His empathy, dedication, and professionalism reflect the very best of compassionate care, and we are proud to recognize him with the Star Award.
You gotta come over here because I want a picture of your best side. Congratulations, and we appreciate all that you do.
All right.
Oh, a close up.
Yep.
And while they're taking the pictures, I'll
Do you mind
just
if I shift you guys over just this way a little bit more?
No,
Okay.
we'll try to keep this pose.
Thank you.
remind everybody that we give a Star Award every quarter, and it is
It's a great moment.
it is the staff within the committee actually vote, and we don't know necessarily names. They just give the interaction, and so we want to give to somebody each time that that demonstrates the care that we want to provide. So Dakota, I feel like you do that, and thank you.
Thanks.
few times. In multiple states of weather and multiple modes of transportation. And honestly, I've always been searching for the word to put on him, and adorable. I'm like, yeah, that was it. But, you know, I got to work with most of these EMS guys and appreciate them all, you know, on the community for the search and rescue, and just so you guys know, we're, the EMS situation is foremost on our mind, and man, we're digging and scrapping and trying to figure it out. So I just want you guys to know that. And it's something that we're hoping to get a resolution. So thanks for looking.
You bet. Override there.
He's on.
Oh, are you doing the? We'll have Clint. First of all, let's talk about consent agenda. Anybody have anything they want to talk about? I had a couple of questions.
Thanks, guys. Thank you.
Thank you. Thanks, everybody. Some of my comments, Andrew, I can just hand you afterwards. There were a couple of minor changes in the minutes. Tanya, on our ballot sheet.
So we're going back. So we need to do chief of staff report.
Did I miss something? Oh,
So you have changes to the minutes? They will just approve the minutes.
no, these are the finance committee minutes. That we'll just barely put in, and I'll get with you afterwards, or just a couple of stuff. Chief of staff report was in the packet. Anybody have any questions? I don't see the chief of staff here to do any additional reporting. Before we go to the consent, or have a motion on the consent agenda, would you look on the balance sheet for this time? But it was last month's. Something doesn't track there for me, Tanya.
For June or for May?
What's that, or Scott?
For May?
Yeah, May doesn't track with the end of May last month under liabilities. The total's the same, but I think it's just difference in the net position and the liabilities.
Okay.
And it has no material effect on anything we're talking about today, but something's wrong in that formula in that spreadsheet.
Okay, we'll take a look at it.
Thank you. With that, does anybody have any, I guess we're looking for a motion on financial results. Anybody want to pull anything else out? Or anything out? Then I'm looking for a motion on financial results and statement of position of high-level operating statistics. June.
Consent agenda. So move that we approve the consent agenda as presented.
True.
A second.
Moved by Mindy, seconded by Clint. Any further discussion? All those in favor?
Aye.
Okay. And we're on to the finance committee report.
All right, Mr. Chair. Meeting held on the 23rd of this month, 3 o'clock. Prior finance committee meetings, minutes from June 26th meeting were approved. Review of financial statements for June for the month and 12 months ending June 30th. Noted the statements are pre-audited and will have a few refinements before being transmitted to IPA, the audit team. Balance sheets item discussed, days cash on hand is 30.5, marking steady improvement. Days in AR, 48.3, marking the lowest mark since Epic Go Live. Net AR did increase approximately $1 million due to strong June revenue. Estimate of Medicare receivables related to fiscal year 24 cost report amendment remains at $750,000. Estimate of Medicare payable related to fiscal year 26 cost report remains at $675,000. This amount will be adjusted at the close of the audit. But given the fact that the second interim rate review went through May 2026, this amount is deemed conservative. Statement of operations items discussed: net patient revenue For the month, 10.5 million strong and driven by increased volumes across all areas of the hospital. Commercial payer mix increased more than planned. So that was nice and contributed to a higher revenue. Medicare mix was unexpectedly lower at 45% compared to May at 50.5%. Net revenues were more than planned for the month by $1 million, but lower than the plan for the year by 2.6 million, primarily driven by the payer mix pressures. Earnings before depreciation, 1.018 million, and a few year-end adjustments that positively impacted this number. One, decrease in supply expense due to the year-end inventory accounts for about $400,000. And two, increase in IBNR reserve of $300,000, an adjustment that is booked quarterly based on health plan actual results. EBITDA was $200,000 more than planned for the month, but $2.6 million lower than the plan for the year. This basically means that the operating expenses were right on plan for the year at $111.6 million. Net income, approximately $308,000 for the month, and a loss of $3,480,000 for the year. Debt service contract ratio for the year ended at 1.54, above the covenant of 1.3. June disbursements approved. A few disbursements were discussed, $100,000 to the Samaritan Fund related to employees being accepted to the fund for the coming year, and 2 UMR payments, a total of 174 payments to non-Star Valley Health providers, totaled $901,235, a very high month compared to average. The July PACE report was discussed, and all indications pointing to a month that could exceed June's performance. Medicare mix continues to be unexpectedly lower than forecasted around 40%. Other matters discussed. Fiscal year 24 amended cost report still in the process due to the daily time constraints. Meridian audit of fiscal year 23 cost report. Initial desk review phase is completed, resulting in a $4,000 positive adjustment. Second phase almost completed. Actual audit will be conducted in September. Since this is the first time the hospital's cost report has ever been audited, it will be an interesting experience. The challenge for our team was that none of them were in place for most of fiscal year 2023 and 23 was the cutover year from Meditech financials to NetSuite. So providing audit requests, Meridian is difficult, but not impossible. Fiscal year 26 audit of financial statements, audit team on site the week of August 10th through 14th. Audit is expected to be complete substantially quicker than last year. Presentation to the board planned for October. Fiscal year 26 cost report anticipated to be filed before the end of October, approximately 1 month sooner than last year. Optum working capital loan, $2.5 million offer from Optum has been approved and is available. Management's decision to take the advance and bridge two things. One, timing of the rural health transformation funds expected receipt date, and 2, continued subsidizing of EMS in fiscal year 27, and 3, timing of the harvesting of cost reduction plans over the next 6 months or so. Rural health transformation funds management is substantially complete with the application for the RHT funds, which is due on or before August 2nd. Fund awards included in the application: EMS $2.25 million plus, emergency department $250,000, stroke and trauma services $250,000, ER, OB and OB/GYN $750,000. Timing of the funds is expected to be soon following the October 31st determination date. Still uncertain. That is my report, Mr. Chair.
Questions? I have a couple. IVR, Scott, what's IVR stand for?
IBNR.
Not IVNR, just IVR. It's in the minutes of the current meeting. The lag in IVR will be watched. What is?
It should be IBNR.
Oh.
Incurred but not reported.
Okay.
It represents at any point in time we have claims that possibly are incurred in the period we're talking about, but have not been reported, so we have to estimate what they may be. It's one of the largest reserves on our balance sheet other than AR. It's generally You know, it's what we do is we look back 24 months. It's called a 24-month lag report from UMR. We get that. It shows what we actually pay out in claims related to a given service date over the past 24 months. And using actuarial methodologies, we try to estimate past is telling us about what could be in the future, about, again, incurred, but we don't know anything about them, but we know they're out there. So that's what it is.
Okay, so I misplaced my list of questions, so I have to hopefully remember. One is the, what's the new fund? Not Samson. Samaritan. I'm a biblical guy anyway. Samaritan, would you explain that one to me? Sounds like we pay premiums also.
Yeah.
As I read, I think that's all in the minutes a little bit, so. Just
Not premiums.
We call it, we have to pay it if
It's called premium in the minutes, I think, so that's what caught my attention.
you can treat it like a premium, but it's a fee that we, if an employee applies for, had an application, invited every employee to apply if they thought they'd benefit. If they're accepted, then the hospital pays a fee, whether it's based on a family or an individual, have them join the Samaritan Fund program.
One-time fee or
It's a
monthly
one-time a
fee?
year.
Once a year?
Once a year. Trevor,
You got an idea what that is?
Yeah, it's about 55,000.
It's 50, it depends on how many people move over, but the starting fee is $55,000 for an individual, and then $15,000 for each dependent that moves over, up to a maximum of $100,000. So that fee.
Annually, we'll pay 55 plus 15 for each dependent.
Yep. And
Is
so far.
Is it child or dependent?
Dependent, which could be a child.
Could be a spouse or, okay,
Yeah.
could it be either of us?
Yeah.
Okay.
And then what that does is, those individuals actually move off of our plan, our insurance plan. They work with Samaritan Fund. Samaritan Fund helps them find an exchange plan. And with the exchange plan, those individuals are provided with a debit card or an HSA card that covers, it helps them to pay their premiums. It also helps them pay any of the out-of-pocket expense that they have. And so individuals who qualify for that are able to get their health insurance without any out-of-pocket expense to them. They're on the exchange plan, so that moves.
When you say the exchange, Wyoming doesn't have an exchange, you're talking,
Blue Cross.
Blue Cross in Wyoming, but it's, the, ACA, it's
Yes.
a marketplace.
Yeah, this is the marketplace. They get a plan, and Samaritan works with them to make sure that the plan that they get covers any of the medications or any of the, a lot of times these individuals will have pre-existing conditions or ongoing chronic conditions that are quite expensive. And so they'll make sure that the plan aligns with that, that's going to cover those costs. And then they move off of our plan onto that plan, and we pay a fee for them to do that. And what it does for the employees is it reduces their out-of-pocket expense and helps them, but it also helps Starlight Health's insurance plan by taking that risk off of the plan and moving it onto another exchange plan.
So I realize it's not called a premium, but what's the difference between the premium we pay for a family and the 55,000 at the minimum?
Well,
I mean, how much savings do we have per year?
yeah,
per
so
employee?
it totally depends on, it's really less about their premium, because our premiums are really based on claims, and more about their potential claims and what they would be on our plan and what the new fee costs to move them over there. And so we've done an analysis on each one of those individuals with Samaritan Fund to make sure that the claims that we are not paying now is is greater than the fee that we're paying. So there's a kind of a cost benefit analysis that's done to ensure that this makes sense for Star Valley Health and for the employee.
So I noticed somewhere in one of the notes, just Scott, we save about 800,000 a year on that. I was just,
And that's
an overall for all people, all employees that might go to the Samaritan Fund.
Yeah,
That's an estimate.
And that's a conservative, we feel it's a conservative estimate based on the individuals that are moving off of the plan. Some of the individuals have very expensive drug claims that can cost $700,000 a year.
So this just puts it back on the government through the exchange.
Well, and they have,
Does it?
we asked the details about where the Samaritan Fund gets their funding. And they said that they're, each chronic illness will have like a group that supports them or provides funds to them, and that generous donors provide funds to that group, and then they utilize that funding to help cover the costs for these individuals. So
why do they go on the exchange then? They're going to be having their costs covered by others.
Well, because they do have to have some insurance plan, and it makes sense for them to go on the exchange. And I guess my thought is that the exchange is probably a much bigger risk pool, and so
it's all unhealthy people on the exchange.
Well, but if you have that risk spread across a bunch of different people, yeah. So I don't know the details behind how it works out for the exchange, and
must not work out because we're letting them pay all the expenses.
And I guess
at least that's my thought. And
my thought is we'll take advantage of this opportunity as long as we can. And
understand.
Yeah.
He's sort of tied by HIPAA because he knows what health concerns we're talking about, but maybe I can speak for my own self.
Yeah.
I have 2 children with cystic fibrosis who have $700,000 in drugs annually, and my insurance is good to cover it, but like those drug companies, the pills, like I literally was laid out in front of me, it probably cost them $3 a month to make. But for whatever reason, it's $33,000 sitting in front of me every time. So like when you're talking about what money's going around, typically the drug companies pay into the pool because they are sucking that life out of a lot of people, so they can give you $3 worth of pills.
Understand.
They can write it off to the government as $33,000, but they've got the kinks worked out on that.
So what allows us? It's my understanding because of the plan that we're a number of employees. Our employees can't be on the exchange typically.
Yeah.
What allows the exception? Is there something in the law?
What allows for us to do this is, number one, we have to offer it to every employee, and we can't single out individuals that we know may have high cost claims. So we put it out there and say, look into this, see if you may be eligible. And then what they do is they actually fill out a HIPAA form and provide that to Samaritan Fund. And then Samaritan Fund reaches out to them to discuss their claims and their condition. And then they'll say, yes, you qualify for this, or no, you don't. And if they qualify for it, then they are opting not to take our coverage and opting to move on to the plan. So it's all voluntary, and we can offer this to every employee. We cannot single individuals out, and we cannot. We have to be fair in how we offer it. So and it's an arm's length transaction. We don't know anything about their claims, and we know about their claims, but we don't get into the details of whether or not they're eligible for the program.
Yeah. Okay.
So,
Todd, you got a comment?
Oh, your question, he answered it. So,
okay.
Yeah. But just to reiterate, we're watching what we expected to pay out this year had they not gone on to the plan. It's a fund. We kind of historically know what we're paying in high claims for these individuals that were accepted. So that's how we estimate what we would pay this year. That won't be on our plan.
So I understand that part of it. So the premium that, I mean, we pay some kind of a premium per employee independent, right?
We just pay a fee.
We just pay the one
No,
time.
not Samaritan, just regular insurance. If I'm an employee of the hospital, I'm paying a share of it, you're paying some of it. That's the hospital, right? And I'm wondering what, I mean,
They don't pay that.
that's another I know, they don't have to pay that anymore because we
They're not on the
pay
plan.
55 to Samaritan. And I'm wondering if there's additional costs there that I'd just like to understand.
So we're actually not, we say we have a premium that we pay, but it's actually an actuarial estimate of what we think our plan is going to cost. We're not actually paying ourselves the premiums, we're paying the claims cost. And so we estimate, like I can give you an estimate of what a family plan costs, the actuarial estimate, but that's not, we're not taking that monthly, Scott, correct me if I'm wrong, we're not taking that monthly amount and putting it into account. I assume we're making correct.
So when we're self-insured, all we're paying is claims?
Yes. And the
Okay.
is the claims, actual cost of the claim to employee of the hospital, and they have the work done here, of course. We don't, we pay that by just forgiving the receivable from them. It's another facility, we pay that in cash.
Right.
Mr. Chair.
Go ahead, Dan.
So, now follow the logic. We're shifting high risk from a self-insured plan to the exchange. Everybody that's left on our plan, possibility of us being able to lower our premiums goes up significantly. So think about how, you know, as costs are ballooning for people, we have a self-insured plan. This is one strategy that we have at our fingertips to keep costs down. Because when you're self-insured, your risk pool is 1,100 people. That includes adults and dependents, right? So we got 1,100, and whatever that risk pool is, that's how they're going to price what we're going to have to fund as really, you know, because we're an insurance company. And so as you take those high risk claimants out of that pool, the cost should go down for everybody else.
And the one, there's a couple of fixed costs that we do have on our insurance plan. And so we do pay for a stop loss insurance.
Yeah.
And so that's a premium that we do pay monthly. In addition to that, we pay fees for UMR to administer the plan, and a fee for Buckner to be our broker. So those fees are fixed costs that are built into the plan. So that is a monthly disbursement that would go out. And with this, if our risk goes down and our utilization goes down, I've never seen insurance premiums go down. But the chance is that if we reduce that enough, then our stop loss premium could go down.
Guess we'll find out.
We'll see.
We're going to find out.
Okay. Evanston Imaging, last month, we were going to hear more about that, and I didn't see that in the finance report this month. That's still pushed off?
Yes, we're not prepared to have an in-depth discussion with the board at this point.
When do we expect that?
Well, I think either tomorrow or Friday, we have conversations with attorneys. That the original attorneys that put the partnership together, we've got to vet a few legal things before we make a decision, or at least a recommendation to the board.
I have a question. So if they come to me, I'll probably ask them in the middle of the meeting, but may not come till tomorrow morning. So, anyway, anybody else have any other questions? I think those were mine. We'll shorten the meeting because I forgot my list. Anything? Okay. Thanks for the report, Clint. Did you? Oh, you're ready for your report?
Yes.
Okay. Go ahead.
The Q-SOC meeting was held on Tuesday of last week. Things to know, if you guys saw anything on the agenda, questions about it, let me know, but things to know were about inventory accuracy. No one is counting things on a monthly basis, and it does take a lot of manpower, and it's tracking pretty consistent numbers, so we're gonna switch that to quarterly pretty shortly. He's pretty sick about the outdated inventory loss, but a lot of those are just like a few high-priced items, not lots of little mistakes. And we're still rolling off like Dr. Affleck's remaining stuff that other providers aren't or don't want to use. So we're kind of at the tail end of that. And then there are some items that we have on hand to use in case of, dire circumstance, and the fact that we didn't use them and they're outdated is a win for people. And it's something that organizations kind of expect. So I think he's very aware of what's going on with the ordering and always looking for ways to improve that, but he's pretty consistent. So that's probably the thing to expect. On education, I think Hayden's doing a really good job trying to capture a lot of grant money. So you'll see money outgoing, but a lot of that is the stuff that we're getting through grants to get some good education for providers. Doing a good job with EBS. Nothing really noteworthy. Infection, all of that was good. And I would say on the process improvement, Sadie reported on that, but really a lot more work and effort trying to get on top of how people feel about the billing system. So hopefully we get some more valuable information on that. And Mallory will be sending out monthly reports of quality improvement projects to each department that are affected, just to kind of close the loops on what's being done to improve processes. And that's my report. Any questions?
Quick question for Scott, probably on the inventory. So that's an annual adjustment. Oh, Scott left at this time. I am remembering your name, right?
You are.
Okay.
Thank you.
400,000. Somewhere I read 400,000. It was like $400,000 swing. Today's world is kind of material for us sometimes, and that's why you're going to quarterly to kind of keep those inventory numbers more on target.
So most of our inventory is on a perpetual system, so it's adjusted monthly or actually daily as they count. There are a couple of areas in the hospital that we count annually. Most hospitals do a semi-annual or an annual count, so you do anticipate those large fluctuations at year end. This year, 200,000 of the 400 was because we added inventory from radiology and lab to our balance sheet, which in the past we've not done before. But their inventory items on hand have become material, so we did record that and move it to the balance sheet. So 200 of the 400 is from radiology and lab. The other 200 is from the pharmacy, which that is an annual count.
Thanks.
Yeah, you're welcome.
Any questions for Abby? Okay. Do you have a couple of resolutions? Or?
Yes. Do I present those or do you, Tori?
I think they come from your committee.
They came from the committee.
And you make the recommendation on the board.
Okay, that's what I was thinking. Let me get up there so I can say it nicely. So since it's a voting issue, I make a motion to, I'd like to make a motion to approve the 2026, 2027. These are all three different items, so I'm doing them as separate. 2026, 2027 Care Center Infection Prevention and Control Plan.
Have a motion?
Oh, I am motioning it. Is that how that works? I don't
That's
know.
one way to do it, and you did it. So
Okay, I'm
I
doing
have a
that.
motion on the floor. Do I have a second?
Yes.
Any seconds? Do we have any discussion or questions about the 2026-2027 Care Center Infection Prevention and Control Plan? Doesn't appear to be any. All those in favor?
Aye.
Any opposed? Stands approved. As written.
I make a motion to approve the 2026-2027 Star Valley Health Infection Prevention and Control Plan. Second.
This is for the hospital, right?
For the hospital.
Mindy, we have Abby with a motion, Mindy with a second on the 2026-2027 Star Valley Health Infection Prevention and Control Plan. Any other discussion or questions? All those in favor?
Hey, there were three things.
Any opposed?
Remember?
No opposed, go ahead.
I was saying something wrong and it was like in one line item and they're like, those are two different plans, so there were like 3 items to approve. Give me 1 second.
It goes on, I always saw two. But they are different, one's for the care
Yeah,
center and
here's
one's for
this.
the hospital.
This was something we made a motion on. Inpatient infection prevention plan.
You made a
Care
motion in your
center.
committee?
I did what I was told, man.
They are just the two things.
I think the board is only
Care center
reviewing two
infection
plans.
prevention plan, inpatient infection prevention plan, quality assessment and performance improvement plan. That was a third thing.
Yeah. Your turn.
Should we approve that? Should we add that to the minutes and approve that? Because it's something we did at quality. I'm
Is
gonna,
that a board approval? Some things are committee approval and some are board, so
The,
what do we know?
what was the last one again?
quality assessment and performance improvement
That
plan.
needs to be approved.
So I will make a motion to amend the agenda to include the approval.
Was it in our packet to read?
No,
Not sure why we would approve it.
it's all the same, it's just, it's an annual update, right?
Has
So,
anything changed?
no,
Then I can.
I'm comfortable suggesting you just approve it according to my.
It's called the what? Quality what?
Quality assessment and performance improvement plan. Are those two separate things? No.
So you said yes, there's nothing new added from last year.
Is that good? So that needs to be, the agenda needs to be amended, and then I'm making a motion to approve that.
Is that a 26-27?
Doesn't have
Annual?
a date by it, but it must be.
Okay. So I have a motion to approve the 26-27 Quality Assessment and Improvement Plan. Did I state it right?
Yes.
Okay. We have a motion by Abby. Did I get a second?
Did you say quality assessment and performance?
No?
Let's say, put that in there.
Performance?
Yeah, quality assessment and performance improvement plan.
Plan, okay.
Okay.
And then that, seconded by Mindy. Any questions? Since it hasn't changed, hopefully there isn't any. All those in favor?
Aye.
Any opposed? Okay, ethics is next month in September. So there's no report. Abby, you at the foundation?
Yes, Ally, I hope this doesn't come plagiarized, but your synopsis is what I'm presenting.
Please know that the end is supposed to be Dr. Kerr.
I know how to say that. I got that.
Wrong face.
So you're plagiarizing?
No, I feel like, if I like, she's giving me the notes to speak it how she wants it.
No, I'm just kidding.
I'll omit the first paragraph. So the foundation update, the golf classic went off quite well. That was on June 12th. They raised $24,000 with approximately 13,000 net proceeds. Able to retain many of the team sponsors and gain new ones. I think that's great PR for the hospital, at the very least. Star Valley Half Marathon. This was Lynette Johnson's first year running it as the director, and had almost 300 individuals register and sign in. Tons of employees and auxiliary were there in full support the day before the race and the day of the race, just donating a lot of time. Great energy. The half marathon, I thought it was, well done. And we will have a better report at the next foundation meeting on actual numbers, because she needs to get with Lynette, who's the accountant that works with foundation?
Jared.
Yeah, Jared. What's his last name?
No.
Yeah, Jared Hale. So that'll be great to see that actual numbers from that. Really important, there's a dependent scholarship fund, so there's a scholarship fund that's just for hospital employees' children, and nobody applied for it. Somebody reached out to Ally about it, so she brought it to the board to say, you know, everybody missed a deadline and we didn't award any, and so we discussed in that meeting, we would like to, it's just growing and it's money that's dictated just for scholarships, and we think it's good PR and good for hospital morale to get some scholarships out there. So that is being opened again. It's been open and they have till Friday, August 14th. So that's going out the intranet, and that's, can you speak to it? Has anybody reached out since?
Not yet.
Okay, so we have an applicant, but we wanted to, because we were planning on awarding it to that one probably, we wanted everybody to have another chance. And that was for 2026 graduates. And then do a better job, like starting September 1, of really encouraging the employees to utilize that scholarship for their graduating seniors. The 2027 capital campaign planning, they've decided between Scott and the foundation that a goal of 200,000 to update vital equipment in the OR would be a good, thing to center the capital campaign around. The giving program, so that the playbook that they're utilizing will be implemented August 10th, and they're going for the employee campaign as the first of the 4 pillars, them being board, employee, and position giving. That's the first visible step. That's all one step. So they want to explain to employees that their participation is voluntary and confidential and allows them to donate like a half an hour a time in the pay period, or an hour, or some set monthly. Dr. Millicent and I did suggest that that's a tricky ask given the circumstances that we're in, but they're pretty confident that that's the way to go. So we'll see how that goes. The bylaws were updated to include the executive director position. And then they've added some new members, Dr. Donald Kirk and his wife Martha Hageman and Mike Hunsaker are all, well, I don't know if we have to approve it here, but you
Yes,
voted
we
them into, yeah. So we'll be, I would like to say that very happily put their names forward for your approval at this board meeting. And that is my report. Any questions?
Are any questions? Do you want to make a motion on the
Yes, I do.
new members of the board?
Yeah, I'd like to
Foundation
make a
board?
motion that we approve as a hospital board, Mike Hunsaker as employee board
Charitable
member
Foundation board.
for the charitable foundation.
The other one is election only.
Yeah, it is. Yeah,
Just
on behalf of it, yeah. Dr. Donald Kirk, board trustee, and Dr. Martha Hageman, board trustee. Second.
been moved and seconded that we approve the new members of the charitable foundation board members as recommended by the foundation board. All those in favor?
Aye.
Any opposed? I'm sure there are those that would love to have it non-elected for the hospital board, but anyway, it's not. Okay, auxiliary report. John.
That's a
You didn't
great,
get to that one?
that's a great meeting to go to.
It is so great.
The energy's awesome there, and I go to bed. But Dr. Jensen came in and gave him an explanation, kind of what he does, which was really cool. Talk about some of his spinal surgeries, and he does that. And it's really cool to see people from all different walks of life in from the community in there, seeing and hearing what he does, because I didn't even know. So to have that information shared with that types of surgeries that he does and some of the patient reviews and stuff. That guy was in there, I think he had done some big back surgery on him on like Tuesday. That next Tuesday he was flying home with restrictions, which I guess is kind of probably unheard of for a spinal surgery. But he talked a little bit about that, and then the ladies came in and talked about some fundraisers they were doing. And I don't know if it's still up or not, but there was a quote that they were selling.
Yeah, it's in the Mike's going through. Yeah, Shelley did it. It's in the little shop that has.
So they're selling tickets for that. Recommend it. And they actually have a super cool point of sale thing. You can just go up and buy tickets. They're not free, so they're up in their game on technology. I guess as far as stuff like that. And they talked about the bingo, but I don't.
It is.
It is bingo.
It's on the ranch in August.
At the ranch in August, that's their next big thing that they get ready to That planning course, they asked that if anybody had any donations that they could give up. Silent auction might be something to talk about. Something you could give a donation to those. And that was. That's my report.
Okay. Any questions? John? Okay. Dennis, this is a resolution to commit supporting EMS. It's in your packet. You want to present that, I guess?
Yes.
What's going on behind?
Yeah, so this is required by the Rural Health Transformation Program application through the state of Wyoming. One of the particular questions in our application is, can you point to a board resolution where the organization is committed to sustaining emergency services, OB services, and EMS services? And so when we first got our hands on the application, we immediately called Dell and said, hey, Dell, we need language that shows our commitment, but also defines reality that if we can't financially sustain these things, then we have to pivot and course correct. And I think Dell has done a beautiful job of crafting that language in this resolution. It's been vetted by, it's gone through several iterations, got some feedback from several people in the organization, including the board chair. And so that is the purpose of the resolution.
Anybody have any, let's see, let me bring that up. Questions about the resolution? I have one change in it, Andra. Down at the bottom, if you spell my name Marlo with an E, put my initial A. I'd be more than glad to sign it, Dale.
We'll get that done.
Sorry, it's not Andrew, it's Dale. I think this one.
And make sure you.
I don't know who this guy is.
Don't throw Andrew under the bus.
So, Mr. Chair, I got it. So just, as I read through it, my feeling was, on all the points, can I just read over your shoulder? I mean, your emergency room and stroke, OB, I mean, those things, you know, we don't have any intention of ditching those, really, ever.
No.
So it seemed like this resolution was like, yeah, fine, no problem. But then we get to EMS and it's like, okay, here's a caveat. You come through with the money and fine.
Yeah.
Other than that, you don't? No, we're not committed to 10 years. Is that did I read it correctly? Is that the feel of?
Well, we are trying to strike a balance between having our application approved so that EMS can receive funding, right? And that requires a board resolution. And then the balance of understanding the delicate nature of where EMS is going to be going in this community, which we don't fully comprehend. We have an idea, and we know where we want to, we know the conditions that we want to create so that EMS has a pathway of sustainability. And I think the resolution does a good job of trying to strike that balance. It's at that intersection that we're at, and we're trying to ensure that all of our options are on the table, and depending on the circumstances, we can use those options.
Yeah. Because they're asking for a 10-year commitment, but only 5 years of money. So
That's exactly right.
That's, it's like, whoa.
Yeah. So Marlo that was his first, he raised his hand. What about this? I responded to Marlo saying, okay, get it. But the resolution provides an out for us, regardless of the time. And frankly, if we are able to create the conditions that we believe need to happen in our community for EMS to be sustainable, then I truly believe that the hospital could potentially be involved for longer than 5 years.
Furthermore, this isn't the contract that we're involved with, the counties and the cities.
Nothing to do
This is
with
a
the
resolution, so,
This is,
so I don't really care about the timeline on that, but the problem being when we go to contract with more specifics, you know, not working off the idea, we get the money that everybody's free and clear, like that we would require to see how they pony up moving forward, because people try to act like, you know, we're caught off guard by this last situation, like the contract coming to an end and now they're asking for money. I don't really think that's true, but clearly we need to readdress that.
and please, I would.
We don't have the answers.
Guys, I want to reiterate, I have started this process almost a year ago.
Oh, for sure.
This is not me waking up and saying, oh, we got a problem. This is.
No, but
this,
the problem is that you took care of the problem each year going forward instead of like being like, they still haven't come to the table as they promised to work in good faith. Because I see your language there, again, good faith.
Yep.
So I'm happy with it, so.
This really has nothing to do with the contract.
Understood,
It
I
has to do
agree.
with funding.
That's why I'm like, man, on the
Possible.
10-year thing, it's just.
Mike, you had a comment?
Thank you, Mr. Chair. I wanted to share with the board today, well, during your discussion regarding this resolution, Scott has been kind enough to help us put together a list of the potential dollar amounts that we could be eligible for through this Rural Health Transformation Fund. I think the board has expressed some interest in that in the past. Specifically, stroke and trauma care, we have the opportunity to receive $250,000. Emergency services, meaning emergency department, $250,000. The potential and possibility of partnering with St. John's, since they're the nearest, we'll determine as PPS hospital, to partner with them in some way. There's $250,000 available there, and St. John's actually, if I'm not mistaken, St. John's contacted us and said, hey, could we work something out? Because they're eligible for a $250,000 payment too. And there may be some care opportunities, since we don't offer dialysis here and they do. We could refer patients to St. John's for dialysis and other services for that matter. They may be interested in obtaining some of our services, such as our cath lab, for instance, that could benefit them and us both. So there is that $250,000 available, and that's just for the basic critical access hospital services that we provide. So in addition to that, for EMS, if you're the only provider within 35 miles, there's $750,000 available. If your ambulances are in a state that they need to be replaced, there's $500,000 available for new ambulances.
Is that like one ambulance?
It would actually be about 2 ambulances.
Oh,
And this is per year, right?
This is
this is
This
a
is
one-time.
just for this year.
Just for this year.
We don't know what next year will look like.
Okay.
It may be similar, but we're not sure.
Okay.
On the regionalizing the ambulance EMS service, that's an additional $500,000. By improving our response times to calls for EMS, it's an additional $500,000.
So is that improving over what we are now or improving over a standard?
It's maintaining or improving.
Okay.
But it has to be, it can't be greater than 30 minutes.
Yeah, it can't be greater than 30 minutes. You have to meet the standard benchmark.
We're at 14 right now.
We're 14 something right now. Then on, there's another program called non-Medicaid eligibles. This is kind of the state's interest in providing or in attempting to get into the accountable care programs. There's an additional $200,000 available for that, which I think we would easily qualify for. And then for labor and delivery services, maintaining those is another $750,000. So if we were to, on the ambulances, it says up to 500,000, so we may not qualify. So we feel like kind of a minimum we're gonna be eligible for is 3.45 million. And the maximum we would be eligible for would be 3.95 million. We've budgeted for $2 million of revenue for that. So we feel pretty confident that these funds will be available to us this year. We don't know for sure what next year will look like. Some of the language in the application says you have to renew for the next year's funding. Okay, we don't know what that actually means. So we can kind of bank on the potential of these funds this year. We'll have to see what next year brings. But just wanted to provide the board with that information so we can.
So as of today, are we assured of those funds?
No.
It's just an application?
Yeah, we will submit the application as soon as the board adopts the resolution, if they choose to do so. I'll hit the submit button on the application. And it'll go to the state. It's due midnight, August the 2nd. We'll be notified of the funding available to us sometime prior to September 27th. And those payments should come not long after that, because the funds have to be expended by the end of October 27th. So they want to get the funds out for hospitals to be able to.
Is the notification October 30th?
Ideally.
I think the notification.
Maybe I got those. They notify us October 30th, and we have to expend it by September.
That's exactly right. Yeah. So we won't be notified of our success or failure.
Yeah,
That's the latest.
That's the latest is October 30th.
Can I ask for a point of clarification? Do you have to get the approval for whatever you're gonna get? They tell you the monetary amount that it may be eligible for, and then do you have to spend the money and then send receipts to get it, or do they spend money and then you prove how you spent it? Do you know how the process is?
Yes.
Is my question clear enough?
Yes, and I believe they'll fund the money to us with the expectation that we will hold to our application that we did.
Now, I want to be clear about something. In the guidance that the state gave us is you get the money, there really are no strings attached about how we use those funds particularly. So it's not like we have to spend the money within a full year, which we're going to some degree, especially subsidizing EMS. We're going to have to. But the state is more concerned about getting the funds in our hands so that they can get ready for round 2 of the RHTP process for year 2. Does that make sense?
It makes sense. I'm just wondering if they're asking for a metric, or if they're asking for your financial, how you spent it, or like what you're tracking to justify the funds.
They're not going to ask us how we spent it.
Then how do they know that you're worthy of the second round?
That may be
There's
the
got to be
question
some
for the
metric
second
they're looking
round.
at.
Yeah, well, it's the first.
I'm just saying.
Yeah, what we have to provide is some type of evidence that what we stated on the application is accurate. For example, we have an emergency department that is active in providing emergency services. Somebody from the state comes, looks, yes, you have an emergency department.
Yeah.
Check.
Yeah.
Here's your money.
Pretty basic.
Yeah, it's so they.
Well, like the call time, we can prove what it is now, we can show what it is.
Yeah, this is not like ARPA funds. This is pretty, they're making it as easy as possible for us to get these funds with some limited conditions.
Glenn?
So when it says stroke services, I'm just assuming we've already got a stroke program in place.
Yes.
So we don't have to implement anything to fill that. Okay.
Yeah, a lot of it is to.
Can I speak to that? We have to document that. We have like a response time, and we have a threshold. We like to have the strokes like indicated within, anybody know, 15 minutes?
So to CT.
Yeah,
and then
time to
there's a
CT.
read, and then
Yeah,
there's
and we involve telehealth. We've got like great contacts, and our people can spot it like a mile away. But the only time we fall outside of hitting that metric is when they're like I stubbed my toe And then also I was tingling, I lost sensation of taste. Like, it's like the second thing that they bring up is they don't come in as expressly thinking maybe they're having stroke. So anyway, we're really good on those metrics. It's very trackable. So that one I'm not worried about. I don't know.
Go ahead, Vince. Yeah. Your comment.
I lost my train of thought. What was the question?
I just asked about the stroke. You know, we already have a program in place, we're not implementing anything new to fit that.
So a lot of the purpose of the funds is to maintain existing services. And there is some incentive to start up some new services like dialysis, which we're not going to do just because of the volume. So we're going to partner with St. John's to potentially do that.
So, any other comments or questions on the resolution or amendments to thereof?
Mr. Chair, I think there's a comment.
Would you raise your hand and come to the podium?
It was more like, hey, get up, I think it's your turn.
We'll take that.
The only comment I was gonna make is in relation to stroke care. So Tori mentioned CT. So there's some software that we need to purchase for both of our units down here in Alpine. And then there's another package we need to add on to the Alpine CT. So those are examples of things we've used. The combined cost of those two is about $96,000. The good thing is by purchasing one of them, we currently have a product that we use that costs about $24,000 a year. When we purchase a new product, it's a $7,500 annual maintenance fee. So, you know, it will go down, but this new technology will make it so that when we get the images, CT images, there's a lot of post-processing. They take the pictures, they have to process a lot of stuff. Right now, it's a really manual process. Our system right now is clunky, it's old. And so the new system is much, much easier. And many more of our staff members will know how to do it. So those brain perfusion studies then, which apparently now is the new standard of care, will help us to know before we send off a patient somewhere else, can we give them something right now before we send them off? Should we send them off? Those types of things. And so the machine here is capable of doing what we need to do, but the machine up north isn't able to do all the CT work we need to do for the perfusion studies. So that's why we have to add that part on there, and both of them need this post-processing software.
So we have 3 machines?
So we have 2 machines. So one CT, well, in the health system we have 3 machines, but in Afton we have 1 CT, in Alpine we have 1 CT. The Afton CT already has this CT head type package, we'll just call it. This one doesn't have that package. So we have to add a package on here. Then there's a post-processing software that helps take the images and quickly helps to summarize what it is and put it in the context the doctor can better understand and use. And so this is 46,000, I think, and this is 41,000. This 41,000 piece is a piece that then after the first year warranty, it'll cost us $7,500, whereas the piece we use right now for this costs us about $24,000 per year. So that's just an example of things that we will do with some of these funds that will make care better. If you think right now, if you go to Alpine for the stroke, well, they can't do the perfusion study. So they have a couple options. Just put you on a helicopter, fly you out, or I guess they can send you down here, but the time you're down here, that's 45 minutes. If you're actually having a stroke, that's not good care. So,
Where's our third one at then?
The third one is at the imaging center in Evanston. Not part of this. We would be doing the stroke CT there. Thank you.
Okay, I guess I'm at the point where I'm looking for a motion on resolution 2026-2.
I make a motion that we approve resolution number 2026-02.
I second that motion.
Is that Abby?
Yes.
We have a motion by Clint to approve resolution number 2026-02, seconded by Abby. Further discussion? All those in favor?
Aye.
Any opposed? Looks like it passes. Okay, we're on to the CEO report. Dan?
Thank you, Mr. Chair.
Resolution with the changes to your shall.
Yes, with the, as amended.
Already changed.
Very specific, sorry about that.
I provided the board my written report. I do need to amend and add some items that I failed to initially insert into the report. First is from a market standpoint, the board needs to be aware that Intermountain Healthcare has acquired Idaho Community Hospital, Idaho Falls.
Which one's that? Idaho.
So
Not Irmac.
Idaho Falls Community Hospital is right across the street from Irmac.
Across which street?
Like
North, south, east, west.
the east. They're east of Irmac.
Okay.
Intermountain Healthcare, I forgot the exact year, actually was invited to purchase about a 20% interest, a minority interest, into that hospital with a right of first refusal. So that time has come. The due diligence still needs to take place. There is an opportunity that the deal doesn't go through, but it has been announced, and so you're going to see Intermountain Healthcare have a more significant presence in that market, and it will impact the dynamics that will take place in Idaho Falls significantly. Okay? Any questions about that?
So they're taking a deeper step into Idaho Falls, is that? Okay.
Yeah, their footprint is expanding significantly in Colorado, Nevada. They already have a presence in Montana, and Idaho is I think on their target list as well.
Okay.
Second is Tanya was able to pass out the PACE report. We did make mention of this. I put in my report that our net revenue was going to be north of 11 million in July. We are now experiencing a record month, a significant record month of net revenue in the month of July. It's now north of $12 million.
This is June or July?
This is going to be July.
So if it keeps up, well, we're almost over.
Yeah, so we're
I gotta remember which month.
we're 2 days, we're 2 days away. So the
I gotta ask why. I mean,
well, it's just
July
it's
is
the
not
same.
always.
It's the same song, third or fourth verse. Medicare mix is down below 44%, and our volumes are significantly up across the board. So if you look at the PACE report on inpatient admission, adjusted admission, patient days, outpatient surgeries, you compare that to previous year and previous month and to our plan, you can see that volumes are significantly higher. Some may ask, well, okay, we anticipated the Medicare mix to actually go up during the summertime, and we did. I think what we're experiencing is
about 5 days.
What's that?
We're only about 5 days.
Well, it was.
Anyway.
I think people, for whatever reason, have delayed care, and there was some pent up demand, and people are using their health insurance now, to get that care. So July is probably going to be one of the strongest financial performing months that we've had in a long time, and we're pretty excited about that. Okay.
This doesn't make any sense, though. I mean,
it's the only logical thing that I could.
Well,
I don't have any evidence.
Understand your conclusion. I just.
I don't have any evidence, Marlo, to back that up. I'd have to poll every single patient that's come through the door in the month of July to understand.
No,
So
I just after being all the discussions we had all spring with the weather and other reasons that the payer mix was changing, and now all of a sudden it's flip-flopped at least 180.
well,
Just,
Can I ask, are we implementing the plan where they try to pay or whatever?
Yeah.
That discount plan?
that I think that's helping a little bit.
What day was that? Well,
Well, it started actually when we offered a tax discount back in
February?
February or
Tax
March.
return,
Yeah.
no.
And it's really kind of continued. We just adopted the the payment policy. Now, it has gone down from 30% to, in most cases, 20%. But I think folks appreciate the fact that we are trying to work with them on their bills. So I think as you take a step back over the last 6 months, management saw the trend of the Medicare mix not going down. We had to act proactively and say we needed to reduce expenses. We still believe that that expense reduction plan was the absolute right thing to do. And we have reduced expenses to the tune of, right now, close to $4 million. Now, we're going to actualize even more than that over the year. One of the things that we didn't budget for was, the Samaritan Fund. We're constantly finding other opportunities to reduce expenses, and those initiatives have been outlined in my report, and we'll continue to do that. But we prepared for the worst, and it flipped on us. We can't explain why, but it is turning into a huge benefit for the organization in our turnaround to add days cash on hand. Okay. So we'll see a very healthy margin, and with all the services that we're providing now, and I'll tell you right now, January, February, and March are going to be dog months. This coming year.
You're willing to prophesy.
I am.
After last 6 months.
And if I'm wrong about what I want to do, is I want to say that's going to happen, and then guess what's going to happen?
Okay.
It'll be the opposite.
Reverse psychology.
Yeah, it is reverse psychology. I did want the board, as promised, in the July board meeting, we wanted to give you the final results of our organizational goals that we had. And so I provided that. I also provided the trigger calculation at the very bottom. I have not had this conversation with my management team, but I suspect that we're still going to stay true to the decision to build days cash on hand. There is a limited amount of money that could potentially be eligible for incentive based off of that trigger amount, but I don't think it's enough to warrant a discussion about it. But I did want you to be aware of where we landed with each of the goals. My management team and I are having discussions about the new goals for this upcoming year. Those I'll have those prepared for in the August board meeting, which, based off of our, what we learned through the process, it'll just be the CEO goals, not necessarily, specifically aligned with the management team and other department goals, but they're going to be similar. Okay. Any questions about the goals, the PACE report, or the CEO report? That's my report, Mr. Chair.
Okay. So I guess just so that I understand, and I appreciate you sharing this with us, but we have no decision to make this year.
That's correct.
Based on these, and we didn't budget any decision to be made next year, did we? Incentive or merit pay, I thought we kind of put that all on hold.
We put it on hold, and what we're finding is that this is kind of a circular equation. At the very, very bottom, you'll see the numbers of net cash from operating activities plus net cash from non-capital activities, less long-term debt service, less CapEx, net of borrowing, less total merit payout amount. We won't know, if we feel like we're in a position where we could potentially be eligible, we may start accruing for that. But as of right now, it is not in the budget. Okay.
Like there might, your mind, be a trigger on what the days cash on hand would look like to justify the accrual for funds.
So,
It might be in there arbitrarily, but
well, we certainly want to try to get as scientific as we can.
Yeah.
But if there is an amount that we feel like the organization should be rewarded and it's available, but our top priority is to meet the bank covenant.
since you mentioned that word, can I ask my question I had from finance? You're pre-approved for an Optum loan, and what does that, being approved on this end of Optum is one thing. How are the banks that we're already doing business with feeling about taking on another loan? Are they worried since we're already out of covenant with the loans we have with them?
No. So we're very transparent with First Bank. There's differences of opinion about whether we should do it or not do it.
We haven't done anything yet, right?
No, we haven't. And
Well, I don't know, it sounds like a sale, we gotta buy it. That's what I always hear from my family. Isn't that what you're saying?
yeah, it's
But
like,
I disagree.
here's how much money I saved.
Yeah, and buy it now and you get a deal.
No, we have not pulled the trigger. We want to be prudent with our decision making. We do know that there are some decisions that have been made that if they come to fruition. So we've applied for the RHTP funds. We have not made the decision to decrease services for EMS for that purpose. That makes it more difficult for management to mitigate costs, right? We have this 2023 cost report audit that we're trying to finalize. We don't know the outcome of that. What were the other points that we're trying to
Anticipate.
to anticipate and manage the risk on?
Well, it's really the bridge between today and when we get the funds.
Yeah.
So it's that 6 months, 5 months. So,
We have money in the bank?
of course not.
Oh, okay. Just checking.
Just check it.
Alright.
So Dan mentioned a couple, but our decision not with the imaging center could impact that significantly.
That's another one.
That's an easy solution.
No, it's not.
No, it's not.
Capital cost.
No, it's not.
I know it affects us, but anyway.
So, look, you get the bigger ones. They're the big ones. About $3 million worth of up in the air.
So I the way that I look at it, it just gives us a little bit of flexibility. This is not anywhere going to be in the amount that if we do decide to take it, it's not going to be anywhere close to what we've taken in the past. It's at a reduced rate. They've lengthened the period. But we have dry powder, and that's, you want management to make sure that they have options. And we're sharing with the board that we have some very affordable options.
It would be paid off before the funds from be paid off about the time that we took it as the transformation money becomes available.
Yeah.
So it just kind of bridges that period so we don't have.
It would also cost us somewhere between 35 and 50,000. So that's not a cost reduction in my mind. That's an increase in avoidable costs. So you kind of know where I stand on this one, but I know it's a management decision. And we'll leave it to you to decide.
Okay. All right, that's my report. Anything else? Any other questions?
Any other questions for Dan? FYI, election applications for North Lincoln County Hospital District trustees are being accepted between August the 5th and August the 24th. And I think the election is at the general election in November. So those that are And remind me, who's up for possible reelection? Which four?
You, Abby.
Oh, okay. All right. And we already talked about the bingo at the Starville Ranch RV Park on August the 20th. Any other discussion items? Let's take a 5-minute break before we go into executive session. We'll wait for that. Can we do the vote now to go into executive session and then take the vote? Okay, I need a motion to go into executive session, then we'll take a 5-minute break.
So moved.
Moved and seconded by Abby, moved by Cliff. We're going to an executive session. All those in favor?
Aye.
Any opposed? Are you two in or out?
We're in.
Okay.
Oh, yeah, sorry.
Oh, good.
We're on.
Motion passes. We're at 5-minute break.
Sorry, you did that. I'm like, she